But I did have another kid with almost the exact same story come in, and to me the exam looked pretty similar, and this was back in my day of doing more ultrasounds than I even do now, and I scanned them, same kind of area. And when I look for their patellar tendon, where do I see it? Yeah, you can see all these fibrils running straight. Is the fluid anterior or posterior to it? Yeah. And you're saying with some cellulitis, some cobblestoning around it. So this kid had fallen like 5 days prior, and we're in because they felt like their knee was getting more red and painful. And what's this? Yeah. Where?
I think it's on eye.
Bursitis.
Yeah, pre-patellar bursitis. So Greg and I have both had the joy of having septic bursa. We have each gotten
such a strong word. Yeah.
Well, I got fever and chills when I had my big elbow olecranon bursitis. Greg also had an olecranon bursitis. I feel like it's a POCUS thing. I don't know why. Yeah, so, there are these different fluid areas that can drive your swollen knee, and maybe there's occasionally a role in the knee for ultrasound in telling you what's what. I will say after I did the scan, I went back to my physical exam and was like, oh, I was just kind of lazy. Yeah, the knee feels kind of fluctuant when I push on it, but there's no real patellar tap when I push. And I'd just been like, hey, it's big, it's woggy, it's a joint effusion when it was a pre-patellar cellulitis. But that's also part of my argument about what's the best physical exam maneuver. Is it the physical exam or is it ultrasound?
I have a question for you.
Yeah.
So I was expecting with a bursitis to have a more of a well-defined fluid collection in a bursa. This almost looks more like that fluid tracking along the fascial plane. That would be really concerning.
Yeah. Yeah, I will say I've only had a couple of bursa that I've ever ultrasounded. This was one. Greg's elbow, I didn't ultrasound, but he did, was another. And they don't have a big capsule, they're these very thin-walled collections. And when they're inflamed, it's kind of more impressive that the tissue around them is inflamed than the amount of fluid in them themselves. Did you home drain your elbow?
Mm-hmm.
Okay.
I was really soft too. I even local lidocained myself. I was just going through the whole process.
Yeah.
And then I drained it, and then
Drained it?
So it was after the morning of a night shift. I drained it at home in the morning in bed, and I went to sleep, woke up, and it was just as big as before I went to bed. So it just comes right back.
Yeah.
Did you put lead on?
No, I didn't put lead on. I definitely put some local lido in first, just for fun.
Yours was from a wintertime fall?
Mine was from my bachelor party,
Okay.
where I was dropped from my best friend's shoulders from about 7 feet high directly onto my elbow.
It is a common mixed martial arts injury from trauma when elbowing people.
Yeah.
And so, if I ever had to pretend how I got mine, I would say, fight injury. But my first one came from picking at dry skin on my elbow, which is great. And my second one came the first time I played hockey in 2 years. On my second shift in shinny with no pads on, I fell on my elbow and boom. And my God, I don't know if you had this, Greg, but for literally a year after it, I couldn't put my elbows down like this because it just would kill.
I became weird about it. I'd have to avoid things. Actually, bring it up. I have an acute path here. It's not really useful for people online. We'll look at it later.
We might look at Greg's elbow later. So sorry, everyone, for tolerating our diversion. Okay, we're going to move on to another joint. And this is a 17-year-old male who's overweight. I should say obese, very large. And they have recurrently dislocated their shoulder, and they say they fell, my shoulder hurts, I think it might be out. So the physical exam is usually enough to tell if a shoulder's out, right? Especially in pediatric age group. But a lot of our colleagues who do point of care ultrasound in the adult world are like, are you crazy? I work with a large population of obese patients, and like it can be really tough to tell if a shoulder's out or not. You don't get that classic divot, and you've got someone who's not so cooperative and hunched over. And I mean, yeah, you shoot an X-ray and you'll know, but there are some nice things with ultrasound where like you could potentially make the diagnosis and even give them some pain control earlier. So how do we do these things? Well, this is most commonly done with a posterior approach. So this is taken from the family practice notebook based on coursework from Gulf Coast Ultrasound. So we want to give shout out to people who generated these images. So with your probe running over the scapula to the humeral head, you'll get a view that sort of looks like this, two bony curves on your ultrasound. So you're starting below the scapular spine in an area where you're going to catch the glenoid rim. And there's people who've taken an anterior approach too, and they will look at the coracoid process compared to the humeral head. Both are fine. I find this one to be a bit easier. And you just have to keep in mind that what you're looking for is that the glenoid rim and the humeral head should line up. And in your classic anterior dislocation, the humeral head is going to move anteriorly and hence away from the probe on the screen, like doing some of the orientation in your mind of like where I'm scanning from. The posterior of the patient and where things move is the important things to do ahead of time. So here's an example of what that glenoid rim and humeral head should look like, and how that humeral head drops anteriorly in that posterior approach from the glenoid rim. Now they're not. This bony cortex goes over here, and this anteriorly displaced shoulder moves forward, hence away from you in this posterior approach. Mike Stone, one of the fathers of emergency medicine point of care ultrasound, has some great videos from I believe it's Highlands, where just like here, resource utilization is a tough thing. So you see lots of patients in centers like that with dislocations, and you're like, oh, we're going to provide you with procedural sedation. Only that's going to happen in like 6 hours. And in those 6 hours, have fun sitting there with your dislocated shoulder. We'll try to give you some pain control, but our nursing is stretched thin, and it just kind of sucks. And often it's like the physician is able to go see that patient, just not really able to do much for them because they can't do all the stuff of procedural sedation. So he's got these videos of this large guy with a anterior shoulder dislocation that he has diagnosed on ultrasound, and then taking this same kind of view, but moving a bit more laterally to find the hemarthrosis joint effusion, and then injecting 15 cc's of lidocaine, an ultrasound-guided approach, intra-articularly, coming back 15 minutes later to a guy who's like, I could tolerate a reduction attempt now, and reducing it, and avoiding the drama and long stay and painful stay. So we're probably a little more spoiled here, but just for people to know, there is a bunch of stuff about intra-articular shoulder injections. There's a bunch of stuff about nerve blocks serving the shoulder that you can do in areas like the neck to avoid having to do procedural sedation. And that's some stuff we'll talk about later. We're going to save the nerve block stuff for later.